All right, so as Dr. Callahan touched upon, the clinical and pathologic features alone might not give us the whole story about our patient. And you will find that when you talk with your patients, or you may have already found this, about the importance of breast cancer index and how it can be helpful, the patients sometimes they will cling to things that you discuss with them, rightly so, about their risk status, their lymph node status, how high their Ki-67 was. And so that can be a reason in their mind for maybe why they don't necessarily want to de-escalate their therapy. And so then at that point, we talk about tumor biology and how there are other factors that help us make that decision. Because remember, as Dr. Callahan said, being higher risk doesn't necessarily equate benefit with a particular therapy. Next slide, please. All right, so for example, BCI found that for patients who have what we would traditionally consider to be high-risk disease, so patients with N1 disease who have a positive lymph node, that approximately 1 in 5 or 20% of those patients were actually at a low risk for a late distant recurrence. And more than 2/3 of those patients were unlikely to benefit from extension of therapy. And so if I'm not using this test, then I would have said something to the patient like, the cancer was in the lymph nodes. It makes sense for us to do everything and anything possible to help prevent a recurrence. And that includes continuing your therapy to 10 years. But approximately 20% of the time, I would be wrong. I would be incorrect to advise the patient to do this. And the problem when patients are continuing on therapies that they don't necessarily need, you are continuing the amount of time that they might experience whatever side effect they're experiencing, and they can be quite limiting, right? They can really inhibit their quality of life. And you're also increasing the amount of time that your patient can experience an adverse event. So those are very real risks with these drugs. With tamoxifen, there's the concern about endometrial cancer and blood clots. And with aromatase inhibitors, we're concerned about bone density loss. And bone density loss sometimes is very mild and sometimes it's not. Your patients can develop significant osteoporosis and potentially develop a fracture. So if I can use all the information possible in order to guide patients to make decisions where I can potentially de-escalate their care, then I definitely want to do that. Next slide, please. All right, so going into my first patient case. This patient, she was 49 at the time of diagnosis, and she had initially self-palpated a right breast mass. The workup was completed. She underwent a right breast mastectomy, and here you see the final pathologic staging, which was T1C N1, ductal histology. She had that positive lymph node. She had not a small tumor, just shy of 2 centimeters, low grade, strongly ER/PR positive, HER2 negative, and a low Ki-67. So we initiated her on ovarian suppression plus an AI, and she definitely did not have an easy time of it. She had mood swings and hot flashes. These were helped by venlafaxine, but they certainly didn't eliminate the problem altogether. She complained of sexual dysfunction with vaginal dryness, difficulty with concentration, so cognitive changes, and just, not unhappy, but not totally happy, So breast cancer index was ordered at year 4, and then this was the result. Her predictive value was no. So no, she's unlikely to benefit from therapy. And that could be a little bit surprising, right? She had that one positive lymph node. I think many people would be inclined to continue therapy based on that. And then you see that prognostic result, and it doesn't get any better than that at 1%. And so clearly these are results that I think the patient was pleased to get, and the planned end of her aromatase inhibitor is in December of this year. But I've seen her occasionally, but it just worked out that Dr. Callahan is really the one that's been following her case most closely. And I know that you're the one who gave her these results. So how does it go?
This is the best result you can give a patient.
Yeah.
This is great. And it's just clear, I've got great news for you. And, patients, they want the no. I think most of them want the no. But sometimes the prognostic result is not as favorable. But with the no and the 1%, it was an absolute slam dunk. There was no guilt in discontinuing therapy. And, she felt great about the result. There wasn't any conflict. We were both completely on the same page. So these are the results that I really like to give.